I'm really talking about access site selection for aortoiliac intervention and really talking about some general considerations. It's often evident where you should access based on your preoperative imaging, particularly if you've had a CT or an MRA. And by and large, we usually perform angiography from a retrograde common femoral access contralateral to the more symptomatic diseased limb, especially in those patients in whom we don't have preoperative imaging. But the bottom line for this presentation is going to be that location and nature of the lesion are really the primary determinants of access approach. So from a practical standpoint, common iliac artery stenoses are approached from a retrograde ipsilateral common femoral access, external iliac stenoses approached from a contralateral common femoral access. But proximal common iliac CTOs are generally approached from an antegrade, either brachial or radial approach, while external iliac CTOs are generally approached from a contralateral up and over CFA access, unless, of course, patient has had prior aortobifem, EVAR, or kissing aortoiliac stents, in which case you'd have to come from an antegrade arm approach. In my practice, we use intravascular ultrasound, external ultrasound rather, guidance for all of our access, no matter what, coronary, peripheral, et cetera. In terms of radial access, obviously that's really revolutionized PCI in the last decade, but it actually has become more and more popular in the periphery as well. And there are, of course, a number of advantages of radial access: less vascular complications, avoiding disease common femorals, patients can get up earlier, they're usually out of bed quicker and get out of the hospital sooner, and hemostasis is easy and it's more comfortable. There are, however, some important limitations. Radial arteries are not big arteries. They're prone to spasm and tortuosity. We're very limited until very recently in terms of equipment length, and obviously there are certain things you can't do with radial artery access, like big atherectomy catheters and so forth. So when contemplating whether or not to do it from the radial, I think it's important to really be careful about knowing your distances and how long your access site is from your lesion site and plan accordingly. Fortunately now with the RTP Terumo products, we have sheaths that are up to 119 centimeters with 200 centimeter balloons, and of course these sheathless guides have really been very helpful in terms of allowing us to treat more patients with bigger devices. It's important, of course, to use vasodilators very liberally, a lot of sedation, and in general, angiography non-selectively is performed with 125 centimeter straight pigtail catheter, and selective angiography with multipurpose and vertebral devices. Support catheters are important, obviously need long wires. And I just want to jump in and show some cases here. This is a patient who had occlusive in-stent restenosis of a common iliac artery. Initial angiogram performed with a 125 centimeter pigtail catheter. Got a supracore wire down there to deliver a 110 centimeter shuttle sheath. Cross the lesion with a stiff glide, and then just balloon angioplasty with a very nice result. So this is obviously a quick and easy case to do from the wrist. This is a 63-year-old female who basically came in with right thigh claudication. Interestingly, did not have a drop after 4 minutes of exercise in her ABI, so we thought she's probably going to have just a plain old stenosis. Lo and behold, she had a total occlusion of the right common iliac artery and a very calcified aortoiliac bifurcation. So the question is, how would you approach this? Well, a couple of options. You could go from the right groin retrograde, left up and over, or antegrade from above. In this case, we're, I guess, lazy, trying to hurry up and get through the case, tried a retrograde subintimal access. Of course, it didn't work, and I was like, God, I should have just gone from the arm. And then we did, for the sake of completeness, try a left up and over, and again, probably not the right access. And then finally, came from the arm with a 5 French sheath and a vertebral catheter. We're able to pop through this with a soft glide, crossed antegrade, should have done this from the beginning. And then after exteriorizing the wire with a quick capture, we're able to then perform PTA, put some kissing covered stents for the bifurcation, self-expanding stents, and we're able to get a very nice result. This is a morbidly obese gentleman who had had 2 prior unsuccessful attempts at traversal of the left external iliac CTO. And you can see it's rather extensive. Below the inguinal ligament, though, he had pretty much preserved disease. So again, how would you approach this? So we did obtain, put a small sheath in retrograde, and with that degree of tortuosity, you needed a soft glide and a quick cross, and basically anchored in the hypogastric, we're able to then get a 7 French sheath up and over. used a crosser to try to get through there clean, were able to get through, and then after that it was pretty straightforward to just basically balloon and stent these, and he was able to go home the same day, and thankfully is now claudication free. Another interesting case of a diabetic woman who had significant right calf claudication that had progressed up the leg, and you can see on her initial angiogram she's got essentially flush occlusion there of the external iliac artery, which reconstitutes at the common femoral, and her runoff disease really was pretty benign. So the question is how to approach this. Well, from an antegrade axis, there really wasn't any sort of a good peak or beak there to get in there. So we purposely went into the deep iliac circumflex branch with a micropuncture kit, and were able to anchor a short sheath into the common femoral artery, and then we're able to get through this with a crosser retrograde. And then after, of course, confirming that we were intraluminal, went ahead and ballooned and stented that, and patient really had a very nice result and was rendered symptom-free. Another case of a patient who had critical bilateral internal carotid artery stenosis was referred by a vascular surgeon for carotid stenting. Just so happened that she also had some claudication, kind of poo-pooed that, so we brought her in for her carotid stent, and lo and behold, initial access shows that her common iliac is occluded. Again, tried quickly retrograde. I didn't learn my lesson from the last case, so I just took my medicine, went left up and over, did an abdominal aortogram, again confirming her common iliac occlusion. In this case, though, she had a decent stump, so we were able to just pass a glide wire through there, and then a snare from the right common femoral side. We're able to snare that, and then redirect the wire into the aorta, and then, of course, just finish up with some balloon expandable and self-expanding stents with a very nice result in the end. Another patient who presented with unsuccessful attempt at a right common iliac CTO from a retrograde access, and in this particular case, you can see he does have a reasonable stump there, so we came from the arm from the get-go with a 7 French brachial sheath. We're able to traverse that cleanly, and then after some adjunctive balloon angioplasty and stenting, we're able to reconstruct the bifurcation with a very nice result. And so in summary, we can say that in our practice, we always use ultrasound and micropuncture kits for access. Preoperative imaging obviously is very helpful to really define the anatomy and plan the case. But again, the location and the nature of the lesion are the primary determinants of the access approach. Again, iliac stenoses from retrograde ipsilateral, common iliac stenosis, external iliac stenosis from a contralateral up and over approach, proximal CTOs from above, and external iliac CTOs usually from an up and over approach, unless, of course, the patient's had a previous aortobifem or kissing stents or iliac tortuosity. And I thank you for your attention.